Hello, thanks for coming. We've got a little smaller crowd here than I was hoping for, but we'll record this and put it on a YouTube channel to hopefully get a bigger audience. My name is Ivan Kwapala. I'm with the Farmington Lions Club. We're here today to talk about diabetes. Here to my left, we have Chelsea Heggie. I will let her introduce herself because all the letters after her name, I don't really know what they mean.
Thank you, Ivan. Yes, I am Chelsea, and I'm a registered dietitian here at the Lakeville Hy-Vee.
And on my right, we have Dr. Brandon Nathan. I didn't memorize the paragraph of his credentials, so I'll let him introduce himself as well.
That's no problem. Thank you, Ivan, and thank you to the Farmington Lions Club for the invitation to speak to you all today. So I am a professor of pediatrics at the University of Minnesota. I'm a pediatric endocrinologist there. I've been on faculty there for 20 years and served several roles in that capacity as a clinician, as an educator running our fellowship program, which is for pediatricians that are looking to further their training in endocrinology, specifically pediatric endocrinology. And then I also run the ambulatory clinics serve as a medical director for that. So many different hats where diabetes is prominent. And the last role is as a researcher. So most of my research is focused in type 1 diabetes. Specifically, my niche is in prevention studies for type 1 diabetes, learning more about the precursors to disease, identifying people at risk, and developing strategies to prevent disease from occurring in those individuals.
Excellent, thank you. I want to talk a little bit about why we're here. So one of the pillars of Lions International is diabetes, along with some others like childhood cancer, environment, and some others. But here we're going to focus on diabetes. November is Diabetes Awareness Month, and so we thought we'd put this together to kind of commemorate November being Diabetes Awareness Month. The intent of this is purely educational. There is no intention of offering any kind of diagnosis or recommendations. It is purely intended to offer you information to better inform you in conversations with your own doctor. We've got an hour and we've got a lot of topics to cover, so we'll just dive right into it. Let's first define diabetes. What is pre-diabetes? Who wants to take that one?
If we're trying to define what diabetes is, it's really important to understand what is normal physiology specifically related to a meal that we eat, how our body handles that, breaks those substances down into their smallest components, and then from a physiology standpoint, how the organs in our body help utilize the nutrients from that food in order to provide energy to our cells. Because that's really important to understanding what diabetes is and the different types of diabetes. So when we have a meal, the elements or the macronutrients of that meal are broken down. There's protein, there's fat, there's carbohydrate that are consumed, broken down in your gastrointestinal system, and the carbohydrates are broken down into the smaller particles in the form of glucose. That glucose is absorbed into your bloodstream. And our bodies are designed in an incredible way. There are cells that reside within our pancreas called beta cells, and they are programmed to release insulin as the glucose levels start going up in our blood. They release that at a very specific number. So when we eat a meal that has carbohydrate, let's say it has a bunch of pasta in it or a piece of toast, that gets broken down quickly, the glucose levels start going up in our blood, and our pancreas senses that. Those cells sense the increase or rise in the glucose levels, and they secrete the hormone insulin in response to that. What does the insulin do? The insulin has receptors throughout the body, And insulin is necessary for allowing our cells to use glucose from that meal, allow that glucose to go into the cell where it can be used and broken down further as a source of energy. That's our preferred source of energy for the cells in our body, specifically our brain, but all of the organs and cells in our body prefer to use glucose. Without insulin around, those cells cannot use the glucose that's in our bloodstream. So I think that's very important. So when we talk about diabetes, the reasons diabetes refers to high glucose levels in the bloodstream that oftentimes manifest by people having glucose in the urine, because the kidneys can only filter a certain level of blood sugars or glucose levels before that glucose starts spilling out into the urine. And that makes people have to urinate more frequently. It pulls more water into the tubules. They urinate more frequently. They get dehydrated. They drink more. So that usually is one of those signs of diabetes occurring. So those elevated glucose is the sort of primary sign of diabetes, and that can happen for a number of different reasons, but the two primary reasons are either your body has stopped making insulin, you're insulin deficient, and that is what we think of as type 1 diabetes. That is an autoimmune process that leads to the destruction of those beta cells to the point where someone is no longer able to generate enough of an insulin response to a meal and glucose levels stay high. The other primary form of diabetes, or type 2 diabetes, which is much more common, refers to also an inability to secrete enough insulin to maintain blood sugars, but it's rooted in a different cause. It's rooted in the body becoming resistant to the effects of insulin, so that the pancreas has to generate more and more and more insulin to overcome that resistance until it can't keep up anymore, and then glucose levels start rising again. Importantly, in type 2 diabetes, people are still making lots of insulin, much more than in type 1 diabetes, but they are also at risk for progressive loss of insulin capacity over time without appropriate attention to their disease process. So diabetes really refers to high levels of glucose in the bloodstream for those two primary reasons. There are other really fascinating reasons that people can get diabetes, which we don't have to get into. They're much more rare causes, single gene disorders, that tends to cause some of those symptoms.
So basically, if we boil it down, the type 1 diabetes is the inability of the pancreas, the beta cells in the pancreas to create insulin, right?
Yeah, it's not inability to make insulin so much as it is the numbers of cells that are there are decreased substantially. So people at the time of diagnosis for clinical type 1 diabetes tend to have about 5 to 15% of the beta cells that they were born with left. So those number of cells are no longer able to secrete enough insulin. The goals of a lot of the research that is going on, and where the future of, I think, type 1 therapies are to try and keep the immune system from progressively destroying the rest of those beta cells, so maintain that little bit of insulin secretion that people with type 1 diabetes are able to do, usually at diagnosis, and then is lost over time. And then B, is there a way to replace beta cells for those individuals so that they can continue to make insulin for longer periods of time? And that is a really tricky process to try and figure out. But there's great research going on. One of the ways, for example, is in transplantation, either pancreas transplants or islet cell transplants. Those come from another person. So those are generally reserved for people with much more labile diabetes in adults who have more severe hypoglycemia or low blood sugar episodes. And there's obviously not enough islets or pancreas to go around for everyone that needs one.
Next question I have is, I've heard that A1C is kind of the gold standard for determining if you have prediabetes or diabetes. Maybe Chelsea can talk to you a little bit about that. What is A1C?
Yes, absolutely. So our A1C looks at your average blood sugar level over the past 2 to 3 months. So you may get a fasting blood sugar level when you go to your doctor, your physician, and that looks at your blood sugar level in that snapshot of time. But it's really nice to have an A1C, hemoglobin A1C lab drawn, because it's not looking only when you're eating, but after eating, when you're sleeping. So it gives you that average blood sugar level over the course of 24 hours and then over the past 2 to 3 months to really determine how your blood sugar levels are doing in regards to your diet, to your lifestyle, and then of course to how your body functions.
Hey, did you have something to add to that?
I'll just add a sort of, I think what's a really important historical context, just to add to what Chelsea was saying. The A1C test probably has changed the way that we take care of people who have diabetes from how we used to take care of them back in the 1950s and 1960s. Back then, we didn't know what are the best ways to try and prevent some of the complications that we know occur with diabetes mellitus. Diseases of the eye, diseases of the kidney, premature heart disease, nervous system disease. There was no evidence behind what are the best ways to do this. So back then, therapies when somebody had diabetes were fairly minimal compared to today's standards. It was 1, maybe 2 doses of insulin, check your blood glucose levels once or twice a day, try to avoid severe hyperglycemia or high blood sugar levels so you're not in the ER, and really low blood sugar levels. And it wasn't until this really landmark study called the Diabetes Care and Complications Trial, or DCCT, that utilized this test called the hemoglobin A1C to monitor people who were being treated with the standard of care back then, as I described, and then a more intensive diabetes regimen, which is very similar to what we do nowadays. Multiple insulin injections per day, more frequent testing, and looked at the outcomes of those individuals, both their A1C and then complication rates. And it turns out that the hemoglobin A1C was a predictor or associated with all of those micro and macrovascular complications. So all the things that I listed before, the higher your A1C went, the more likely you were to have those complications. And those that maintained their hemoglobin A1C levels in a lower range had much less prevalence of those complications. So that became one of the reasons why we look at A1C, both for how somebody's doing with their therapy, how their blood sugar levels are controlled, because we want to keep that low to prevent complications for those individuals. But as Chelsea was saying too, this is also a way that we've used, that we diagnose people now with diabetes.
Can we define A1C a little bit better? What are we checking for when we check A1C?
So the A1C test really is a measure of how much glucose gets attached on to the hemoglobin A1 strain within the red blood cell. This is a process that's happening normally in all of our bodies. Normally, we have somewhere in the neighborhood of about 4.5 to 5.5% of our cells, red blood cells, that have glucose attached onto them. So anybody who doesn't have diabetes, that's the sort of normal range. As Chelsea was saying, as your glucose levels start going up in your blood over time, there's more of that glucose available for that enzymatic reaction, and more of that hemoglobin gets glucose attached to it. So from a diagnostic standpoint, if you are found to have 6.5% of your red blood cells or your hemoglobin A1C levels, that is considered to be consistent with a diagnosis of diabetes mellitus. If you are in a range of about 5.7 to 6.4%, that is considered to be in a, quote, pre-diabetes range. And that means that you are someone that's at risk for progression to more fully developed clinical diabetes.
And then, as I understand it, the hemoglobin has a lifespan of 2 to 3 months, and that's the reason for the timeline of that test?
Exactly, yes. So that it takes advantage of the normal turnover of red blood cells in your body. So disorders that sometimes that can have increased red blood cell turnovers can cause, some changes into the A1C test that we have to watch for, but most people, it's just, like was mentioned before, around 2 to 3 months gives you average glucose readings over that period of time.
How, maybe real quickly, we can just go over how prevalent is, let's say, type 1 is much less common than type 2, as I understand it. Do we have a ballpark? How many Americans are affected by diabetes?
So there's about 300,000 Americans that have type 1 diabetes. Many people sort of think, well, that must be kids because type 1 diabetes is like the pediatric or childhood version of disease, and that's actually not true. There are more adults diagnosed every year with type 1 diabetes compared to children, even though we think of it that way. It is dwarfed by type 2 diabetes, which is much more prevalent within our population. I think in the neighborhood of about 39 million Americans have type 2 diabetes. Of those individuals, 2/3 have been diagnosed, and 1/3, or about a quarter or so, have not been diagnosed. So they are walking around with diabetes and they don't yet know it. Close to 100 million people are in that pre-diabetes range. So if you put those two together, it makes up close to half of our adult population with pre-diabetes or type 2 diabetes. So it is a massive, massive problem. That's not news to anyone, but that's why there is so much discussion about it, about ways to prevent, what you can do for yourself if you have pre-diabetes to prevent, progression of the disease.
I think that leads me really well into the next question that I have. Is there any symptoms of diabetes that you can anticipate that you might have it? Obviously, the A1C test is probably the best way to determine, but is there any symptoms that you can watch for?
Yeah, sure, I'm happy to talk. When you're, it's actually a really important question because there are many people that are walking around, as I mentioned before, that haven't been diagnosed, but they have disease. So it can be really sneaky, even in kids. The first symptoms that people are going to have when their glucose levels start going higher, again, will start spilling glucose in their urine, and they will urinate more frequently. So we talk about that a lot for recognition. If you have a child that is potty trained and all of a sudden starts urinating more often, or bedwetting, or getting up in the middle of the night multiple times, this is something you should be thinking about. That's usually mixed with those same individuals feeling very thirsty all the time because they're getting dehydrated, so they're drinking quite a bit. If that goes on for a long enough period of time, that is associated with weight loss. So some of the reasons, people might not come in is because they're losing weight, and they're like, oh, this is something I wanted to have happen. I'm losing weight. Why are they losing weight? Because their bodies are not able to use the nutrients and nutrition that they're taking in. They're losing most of that out their urine, and their bodies are in a state of catabolism, meaning they're starting to break down proteins and fats, and this results in weight loss for those individuals. That can get very dangerous for some, particularly those that have type 1 diabetes. They can develop something called diabetic ketoacidosis, which refers to people that have high enough glucose levels and enough of insulin deficiency that they develop something called ketones in their bloodstream. And when this production of ketones goes unchecked, their blood becomes very acidic. They have a lot of nausea, vomiting, can get significantly dehydrated, and it's an extremely dangerous situation. It's the leading cause of morbidity and mortality, meaning injury and death amongst individuals with type 1 diabetes. So it's something we try to avoid. So that would be the extreme end of the symptoms. But it's why the campaign is about really screening for people. Know what your risk is and then get yourself screened, because it can be very subtle for some people, especially if they have type 2 diabetes where their glucose levels may fluctuate more, and some of them, they may be in a lower range of the glucose realm. That doesn't mean that they won't progress further and get more severe over time.
Maybe we can touch briefly on benefits of detecting diabetes early. Maybe that's Dr. Nathan again.
Maybe I'll start with talk about type 1, and then Chelsea, do you want to talk about type 2 a little bit? This is a really timely question for type 1. How do you screen for type 1? Why would you screen for type 1? We talked a little bit about the reasons why type 1 occurs. It's an autoimmune process, meaning that the body's immune system has targeted those cells for removal, just like it would a viral infection or a bacterial infection. So we know there are genetic reasons for people to have risk for developing type 1 diabetes over the course of their lifetime. We don't know all the genes, but there are probably hundreds that contribute to that. But the main one is called HLA, or how your immune system is programmed. So we can kind of look at somebody's genetic profile and say, this is someone who is at risk for developing this autoimmune process. Doesn't mean that's gonna happen, just means they're at higher risk. They oftentimes have, or they will have, some type of exposure along the way that triggers their immune system to start this process. And when that immune system is triggered, they will start these proteins called antibodies will show up in their blood, and they're very specific for people that have type 1 diabetes. They're sort of the precursor of disease. It tells us that the autoimmune process is occurring. And it gives us an opportunity to try and intervene. Just because you have antibodies present, that doesn't mean you have changes in your glucose levels or any symptoms at all. You don't feel anything. But we know that particularly children, when they have these antibodies, are going to progress to type 1 diabetes, clinical diabetes. So in populations that are at higher risk, either if you know your genetics or you have a family history or you have another autoimmune disease, there are programs, research programs, as well as your provider that can test for these antibodies. And it's important to do that so that you know your risk. You can prevent more severe complications like diabetic ketoacidosis at the time of diagnosis, which we're trying to do by people knowing their risk. They can be, if they're interested, we have lots of different trials that are going on to try and prevent type 1 diabetes from progressing. And we have medicines now that have been approved that can also delay the onset in populations who have these antibodies who are at a certain stage of that development. So they can be treated and delay the onset of clinical disease. So there are lots of reasons to screen for type 1 diabetes in the right population. We don't screen for it in the general population yet. Some other countries in Europe are starting to do that, and some states are starting to do that as well. So that may be something we see on the horizon.
Yes, thank you. And similar to type 2 diabetes, as a dietitian, I do work with clients to not only help manage chronic conditions such as diabetes, but really focusing on that prevention side as well through sustainable lifestyle changes. And so one thing I do talk about with my clients is that awareness is key. So we don't know what we don't know. and we don't know what we should change. And so by getting your hemoglobin A1Cs completed, if it tends to fall into that prediabetes or happens to fall into the type 2 diabetes range, then you are aware that, hey, we probably need to make some changes in our diet, in our lifestyle. And so, yes, while genetics can play a role, there's a lot that we can do from what we eat, how we eat, our physical activity levels, sleep, stress management. And so if we can implement healthier lifestyle changes, it can help prevent that progression wherever your current hemoglobin A1C level is. Because if we don't take action, similar to type 1 diabetes, complications can arise. So damaging our nerves, it can affect things, our eyes, other organs in our body. And type 2 diabetes is highly correlated with heart disease as well. And so trying to minimize other severe complications by getting ahead of it and working with your physician, working with a registered dietitian to help implement sustainable lifestyle changes to help lower that A1C to get you to a healthier level to really minimize those severe complications that we want to stay away from.
All right, I think we covered that part pretty well. There's obviously a lot more that we could cover, but we've only got an hour, so we're going to have to keep it kind of on the surface. Let's talk a little bit about insulin resistance. I know you had touched on that earlier, but maybe we can explain that process a little bit in a little bit more detail.
That's it. This is a tough one. It's a challenging concept, but the way that we usually talk about it with our learners, medical students, residents, I'm going to use this analogy of a key and a door. And in order for your cells to use glucose, like I talked about before, you need the hormone insulin to sort of unlock that door to allow the glucose to go into the cell. And when your body starts becoming more resistant to insulin, we can talk about why that happens. That key that normally opens that door doesn't work as well anymore. Maybe you jimmy it around and you can finally get it open, or you see that, well, it's not just one lock in there, there's multiple locks in there, so you need extra insulin to actually get that door open and allow the glucose to go into the cell. So the insulin resistance occurs when our bodies tend to develop in a way that promotes inflammation, promotes usually high levels of lipids in the blood, high levels of fats in the blood. These are some of the things that make our bodies more resistant to the effects of insulin. Fatty depositions around our organs causes the body to get more resistant to insulin. Sedentary lifestyles, so when we're more active, if we go out for a walk the dog, play with our grandkids, play sports, all of those things make our bodies more sensitive to insulin or lower our insulin resistance. So if we follow a more sedentary lifestyle and make not as good of choices on a regular basis, that adds to our body weights, and our body weights start going up. So that's where like body mass index or BMI, although it's not a perfect surrogate of this, it's a helpful way to look at it. So if you're carrying more weight for your height, your BMI goes up. And we know that those people who have elevated BMIs or in that range are more at risk for insulin resistance, which is the sort of precursor for development of type 2 diabetes.
So what is it about the higher BMI that leads to insulin resistance? What's the link there?
Well, it's really related to fat, like the lipid and fat component that specifically covers our organs. So the visceral, it's called visceral adiposity. that creates, like I said, inflammation. There's hormones that come out of that fat that increases our insulin resistance. The fat in our blood increases our insulin resistance. So there is, if you look at any study that's out there, there is a direct correlation between insulin resistance, type 2 diabetes, and obesity or elevated BMIs. That's not 100% accurate. There are people in very rare situations that will have insulin resistance for other reasons. And notably in the pediatric population, puberty is a time where insulin resistance starts going up. So when we think about the children that are most at risk for type 2 diabetes, it tends to be kids that have elevated BMIs, follow sedentary lifestyles, have increased measures of adiposity, have some of these changes in their blood. They usually have characteristic cholesterol panels that suggest insulin resistance. Many times they'll have findings on their skin that show that their bodies are working really hard and putting out a lot of insulin, so darkening of the skin and the folds of the skin. And this usually happens around the time of adolescence or puberty. That's when most of the kids will get diagnosed, because it's a normal state of increasing insulin resistance as you move through puberty. So that's where that association occurs between elevated BMI or body proportions and levels of adiposity and insulin resistance.
You have anything to add on that? We're a little bit ahead of schedule, so if we got something else we want to touch on.
Yeah, the only other thing that I'd mention is that as our bodies become more insulin resistant, our beta cells in our pancreas must work harder to overcome that insulin resistance. So that's why your provider might measure an insulin level and see that your insulin level is really high in your bloodstream. It's like revving your car at a really high RPM for a long period of time. Eventually, your engine is not going to be able to handle that. It's going to start breaking down. And that's what happens inside of our pancreas, too. There's stress that happens inside of the cells, and those cells stop working. Some of them actually start dying off, and that's when we start seeing more problems with insulin resistance. So the key thing, with insulin deficiency, not insulin resistance. So the key thing, and I know Chelsea is going to talk more about this, but when you have insulin resistance, you can actually reverse that. Right now, we can't reverse the sort of run up to type 1 diabetes and clinical diabetes, that loss of beta cells, although we're working on it. But in people who have insulin resistance, you can actually modify that or change that by changing the way that you live, your diet, your activity levels, to lower your body's insulin resistance, make it easier for your pancreas and your beta cells inside of your pancreas to make more insulin, or to not have to make so much insulin to overcome that resistance. So it reduces the stress and strain on those cells, keeps them healthier, and keeps you from progressing. That's why sometimes people talk about it's reversible. Type 2 diabetes can be reversible, which is not the case of type 1 diabetes yet. But we're working on it.
You'll get there.
We'll get there.
Yeah, that's a perfect segue into our next topic, which is centered around diet and lifestyle. Let's talk a little bit about carbohydrates, and especially quality versus quantity.
Absolutely. One of my favorite parts to talk about. So one of the biggest ways that our diet really impacts insulin resistance is through the types of carbohydrates that we eat. Now, carbohydrates are important. They are our body's main energy source, like you said, especially for our brain. But what I really like to look at is, yes, the quality that we eat. So carbohydrates are kind of broken down into two major categories. We have simple carbs, and then we have complex carbohydrates. And the impact of each kind of category on our blood sugar varies greatly. So I'll start with simple carbohydrates. Now, these are digested really quickly. We eat them, they get digested, we get an immediate blood sugar spike, and then, of course, a following insulin spike. And so these foods are going to be your typical white breads, white rice, white pasta, any type of added sugars, sugar-sweetened beverages, kind of our baked goods. So there'll be carbohydrates. I call them our fun foods, as they don't have a lot of fiber in them, versus complex carbohydrates. They're digested a lot more slowly, and then we see a much more gradual rise in that blood sugar level. And so they often also contain things like fiber and vitamins and minerals, and they do a lot better for our body. We have more nutrients. And so those foods that we really want to focus on adding into our diet are things like your fruits and vegetables, whole grain products, so brown rice, whole wheat pasta, quinoa, lentils, beans, different legumes, because we're going to have a much nicer blood sugar rise, and it's going to be a lot more steady than we see when we eat simple carbs. You'll get that blood sugar rise, and then we're going to get that dip, and oftentimes we might experience fatigue. We might have more cravings for sugar. We might be grabbing towards some coffee. So keeping your blood sugars more stabilized throughout the day is very, very important. So on that note, fiber is something I really promote in my practice with my clients, not only from a blood sugar stability standpoint, but gut health. We see it benefit our heart health. And so really aiming for, 25 to 35 grams of fiber per day from whole food sources, very beneficial. And then, of course, these foods rich in vitamins and minerals, which are very essential to our overall health, our immune system, and then supporting blood sugar control.
That's great. Did you have something you wanted to add?
I was just going to add that all the things that Chelsea was talking about, many people nowadays are actually observing because they are wearing little devices that we use to help people who have diabetes mellitus monitor their glucose levels. So the application of continuous glucose monitors to kind of the general population, many people are wearing them to sort of look at what's happening to their blood glucose levels even though they don't have diabetes, and they can see this when they eat certain things. So if you, just like Chelsea was saying, like if you have a muffin for breakfast or a bowl of cereal for breakfast, you're going to see your glucose levels change much more rapidly. And you can imagine that as those glucose levels are changing rapidly, your beta cells are having to respond much more quickly and rapidly as well to account for that rise in their glucose levels. That's going to look very different from a meal that has higher amounts of fiber and complex carbohydrates with a protein source, where you're going to see a much more blunted rise in your glucose levels. This is really important for our patients with type 1 diabetes, for example, in trying to sort of help them manage their glucose levels a little bit better and how to give insulin at the same time. So we now have the ability to actually see these changes happening on a minute-to-minute basis, and that's been very powerful for a lot of people.
Yeah, I've used one of those myself. I've been dieting the last several months, and for a period of time I used a CGM just to watch and see how my body reacts to different foods, different diets. One thing that was interesting that I wasn't aware of is a thing called the dawn phenomenon, where you normally have a blood glucose spike in the morning. I was a little bit confused by that at first, but I researched it and found that is pretty common. Let's talk a little bit about calorie deficit, dieting, fasting. Who wants to take that one?
I'll take it. So yes, calorie balance is going to be important. So when we talk about energy balance, we're really looking at, how much fuel are we intaking, and then how much fuel are we utilizing, and how are we utilizing the fuel that we consume through calories. So yes, if we've got if there's some weight to lose, it has been shown that even a 5 to 10% weight loss can greatly impact, our insulin sensitivity and improve that to help reduce, if we've got prediabetes or diabetes, to help reduce that A1C level. But I also like to focus on with clients outside of changes on the scale are behaviors that we can implement long term that enhance how our body utilizes the fuel we consume, the calories we consume, and ultimately impact our insulin sensitivity. And so those can be things like focusing on meal components. So when we're eating carbohydrates, making sure they're complex, making sure there's a source of fiber. Do we have produce on our plate? Do we have protein? Because protein really helps stabilize our blood sugar levels and preventing that big spike. I'll look at also like snacking too. One of the biggest things I'll tell people is don't eat carbohydrates by themselves. So trying to have food pairings, and then really trying to minimize those large spikes that are caused by our highly processed, high sugary foods. And so as a dietitian, I really take approach on what can we add to our diet versus what do we have to restrict. Because anytime I get people focusing on restriction, it's all you want to have, right? So we think about taking something away from a kid. Well, that's all they're going to want. And so in working with clients, I like to take the approach of how do we add more produce to your diet? How do we add more fiber, the lean proteins, the healthy fats, versus focusing on, do not eat X, Y, or Z, because it's kind of like the crowding out factor. The more we add nutrient-dense foods to our diet, the less room we have and maybe the less cravings that we actually get for things like desserts and chips and things like that. And so in addition to, some of these habits, we'll talk about physical activity being very key in enhancing that insulin sensitivity. I also really like to look at sleep health and stress management. I was just on a webinar today, and it was talking about how getting less than 6 hours of sleep can actually decrease your insulin sensitivity by 20 to 25%. So focusing on more of these sustainable lifestyle changes that we can add on in that are very realistic and doable for you is where I really like to start outside of just focusing on the scale.
Absolutely. The only other thing that I would add is that there are different triggers for different people. Everyone's physiology tends to be a little bit different. Some of the signaling for different people can be different. So it's why some individuals really struggle and weight loss or weight stability is a real challenge for them. So there are many programs, clinical programs now to help those individuals trying to identify, what are those changes in signaling cascade. We do this for pediatric patients. There's adult weight management programs too, throughout all the different healthcare systems. And they're really there to design, not just following the great advice that you just heard about, but how do you avoid some of those situations, or are there medications that might actually help you reduce some of that drive to eat all the time, or lack of satiety after a meal? And this combination of approaches of dietary interventions, really changing things for the better there, along with some behavioral approaches and sometimes pharmacologic approaches, can really make a dramatic difference for people in terms of reducing their risk for type 2 diabetes moving forward.
Real quickly, can we tie the diet? I know we kind of did before, but maybe we can make that connection a little bit better. Where's the value in dieting in connection to diabetes?
Like I said, with dieting, so being in a moderate caloric deficit, it can help reduce that body fat. And so we do see, by reducing that body fat, we can enhance that insulin sensitivity, which can help lower your A1C level and prevent your risk for diabetes. like we said, though, some people, right, I will say weight management is not just calories in, calories out. We have to look at the physiological aspect as well. And so that's where I've had clients where they say, I've been in a deficit. I'm physically active. So sometimes it is that step further to really individualize that piece, and talking with the physician about, what help can I get to enhance insulin sensitivity, to enhance your body to utilize that fuel better.
If I may, just asking you a follow-up question.
Yeah.
How do you feel about, different diets that come across every year or two? There's always fad diets that really help people lose weight on a real rapid basis. What's your advice to those individuals if they are thinking about that for reducing their risk for diabetes?
Absolutely. So when it comes to any way of eating, I will always support somebody in helping them to do it in the healthiest manner possible. However, we have seen a lot of the fad diets, the ketogenic diet, paleo, what's the very high protein? Oh, I'm blanking. Carnivore. They kind of cycle through. The biggest things is that, yes, they are going to work in the short term, right? You're usually restricting a food group, which naturally reduces the amount of calories we consume. So in the short term, yes, you will likely see weight loss. My biggest approach is, can you maintain that way of eating long term? So, for example, maybe it is the ketogenic diet. We're reducing our carbohydrates. Carbohydrates do retain some water, and so we might see, quicker weight loss. However, can you eat low carb forever? And we know there's a lot of benefits from our complex carbohydrates. So really looking at, are we gonna have other deficiencies? And so if somebody wants to approach one of these new diets, I like to ask them, what is your hope out of this? Can you maintain that long term? And if not, we'll find an approach that works the best. And I really take a protein and fiber forward approach. Whole foods, rich in produce, because that's something that we can maintain long term, versus, dieting for 2 to 3 months and then realizing, oh, I miss these favorite foods. And so I like to approach and how can we incorporate your favorite foods, but making sure this fits your goals and improves your health in the long run.
Would you say the benefit of dieting from losing fat versus having a lower daily intake of carbohydrates, which one is more beneficial in terms of diabetes and prevention? Reducing body fat versus reducing your daily intake of carbs?
I think they kind of go hand in hand, actually. So if you reduce your simple carbohydrates, you're going to lower your blood sugar levels. You're going to actually produce less fat. So it's not just like fat consumption doesn't mean that you're going to put on more adiposity. Many times it's actually high glucose levels or high consumption of simple carbohydrates that actually leads to more adiposity. So those two things are not separate from each other. They're actually related.
Right, but as far as diabetes goes, your risk for diabetes, I guess what I'm trying to get at is it more because of a high blood glucose level or a high adipose amount?
Yeah, I think it's a complex answer. I think
that's why I have the experts here.
It's all of the factors that actually promote a more insulin-resistant state and make it more challenging or difficult for your body to overcome that resistance. So a high carbohydrate diet can do that. When you have a predisposition towards putting on, you're more efficient with your utilization of calories, and so that's why some people can eat all day. They don't seem to gain any weight. Others can't do, a fifth of that. If you're more efficient, if your body's more efficient and you're more likely to put on more weight, that's going to contribute to your risk. And then we know there's also different genetic factors for type 2 diabetes or specific genes that we know increases your risk. So most children that go on to develop type 2 diabetes in childhood, almost a very high percentage of them that have a mother or their father that has type 2 diabetes too. So there are genetics behind that as well.
And when you're talking about genes, you're not talking about Sydney Sweeney's genes.
That's correct, yes.
Okay. All right. We're coming up on pretty close to an hour here where we're going to have to run, so I guess we should talk about exercise a little bit more. What specifically can we talk about benefits of exercise in terms of diabetes and prevention and whatnot?
Absolutely. So exercise is a very important tool when improving our insulin sensitivity and reducing insulin resistance. And we can typically see effects right away. Muscle really acts like a sponge for glucose. And so when we are regularly physically active, our body can utilize glucose more efficiently. We respond to insulin more effectively to reduce those blood sugar rises. And so even a single bout of physical activity can enhance your insulin sensitivity for 24 to 48 hours after that exercise. And I do like a combination of both aerobic exercise, so whether that's walking, biking, swimming, running, dancing, whatever you really enjoy, because ultimately we need to enjoy what we do so that you can keep up with it. But pairing that with resistance training or some strength training to really promote the muscle mass, because of that muscle being very sensitive to that glucose. And so resistance training helps build the muscle, but it also helps reduce that visceral fat level, which is that dangerous fat around our organs that is very highly correlated with insulin resistance. So typically, if we look at our recommendations, we're looking at 150 minutes of moderate aerobic exercise a week, and then 2 to 3 strength training days. However, I realize if we're not there yet, we want to take a smaller step approach to help you get there. And so breaking that down, maybe it's 30 minutes of walking 5 days a week, or implementing what I like to call movement snacks. So even 10 minutes sprinkled in throughout your day. And one time that I'll really encourage people is if you can get some movement after meals. It really enhances your insulin sensitivity and reduces your blood sugar rise. And if there's one meal that I'll tell people you can focus in on, it'll be that evening supper time. We tend to become more insulin resistant later in the day into the evening. And so if you can go for a walk, if you can walk around your dining room table or do some body weight squats, different things like that, especially in the evening, I will encourage patients just to implement and enhance our insulin sensitivity and keep our blood sugars more stabilized.
I think you hit the nail on the head. We talk a lot about finding what types of activities that you enjoy. So you don't have to be on a treadmill for an hour if you don't enjoy that. Find things that, if you like to dance, go dance. If you want to swim, go swim. If it's walking your dog, walk the dog. It can be all kinds of different things. It doesn't have to be these crazy strenuous activities, but you can work your way up there. So start small and then continue to build off of that. What we didn't talk about is the benefits psychologically of actually starting to exercise and feeling good about what you're doing and seeing the results of what exercise can do for you. So that's an intangible that I think is incredibly important. The pull is always to go back to more sedentary, and so you have to keep up with it and stay active and really keep pushing yourself. That's why it's important to find those things that you really enjoy and doing it with someone else.
And I think I would just like to add too, outside of the mental benefits, the physical benefits of exercise, exercise really positively impacts our stress management. It impacts our sleep, and we know all of that plays together when it comes to blood sugar control. So there's a lot of benefits outside of just our physical health and emotional health when it comes to physical activity.
Yeah, I mentioned earlier I've been dieting the last several months, and I've lost a pretty significant amount of weight. I don't want to exactly spell out how much weight I've lost and how short, because I don't want to give anybody false expectations of what they should be able to do. But I can definitely tell you that the confidence level, the energy level, all the positive changes that have come from that have far exceeded the pains that I had from my dieting and my weight loss. I just have to get back to something that you said earlier, Chelsea, about your exercise snack. I'm assuming that does not mean getting up off the couch to go to the fridge.
No, it does not.
That's the kind of exercise snack I used to like, which is why I needed to diet. I know we had one question from the audience. Maybe we can touch on this a little bit. It's maybe a little bit off topic, but that's okay. The question was about artificial sweeteners.
Yeah, so artificial sweeteners can be recommended when it comes to those with prediabetes or diabetes, because they don't have any calories. They won't affect your blood sugar levels, and so they can come into play. So stevia is one that I will utilize as an option, because to me it's more of a natural artificial sweetener, if that makes sense, versus things like aspartame and sucralose. Those are more man-made. And so the only thing I'll look at is that there has been more research out there about artificial sweeteners and our gut health. And so overuse can negatively impact our gut health, and gut health is greatly tied to a lot of great things: our immune system, chronic conditions, autoimmune diseases. And so I do not recommend the overuse of artificial sweeteners, but for those who might want to utilize them in place of higher sugar options, it can be an option to help better support more balanced blood sugar levels.
All right. Any other questions from anybody? If not, I think we're going to call it a wrap. Thank you, Chelsea. It's been a pleasure.
Thank you, Ivan. Appreciate it.
Dr. Nathan,
Thanks again for inviting me. Yeah.
been a great pleasure. Thank you both.